So good evening again, everybody. Thank you. So for those that don't know me, my name is Stuart Schlossman. And a lot of you, or many of you already do know me from whether it be one of these programs or somewhere where I may have been speaking, or you might see us on social media, or you might see us on Blog Talk Radio. Well, there you can't see us, you can only listen. We do Blog Talk Radio. We get different people that we interview every now and then, put it out there, whether it be for stem cell therapies or some other alternative therapies, or we talk about the different drugs that are out there, or nutrition or something. But there are different things that you can listen to with our programs on Blog Talk. How do you get to that? Well, from our website, which somebody took down and I can't see right now, but from our website, yeah, this guy can do that. By the way, this is Bill, everybody. He's good with this stuff. Hey, Bill, see that? All right, so from the website on the blog and video, I could get to that, but all right, right there. So right there, well, right there was, and it still is, or it's coming up again. You can see the different things that you can get to for our YouTube channel, Blog Talk Radio, and other things, other resources that you might need on the internet to find whatever you'd like to find out about multiple sclerosis. Everything from this website you can jump to and find and access actually in other MS organizations' pages as well. Also, many of the pharmaceutical people are on here too. And from the pharmaceutical pages, you can find out information about their programs, maybe one of their calendars of what events they have going on. Recently, as of today, yes, that one. Recently, as of today, MS Atrium, who's the patient website for Genzyme, Abagio, now has MS Views and News as one of their primary resources for patients to find. This is great. Yes, this is great, because people from all over the world will now click on who we are and what we're doing for the MS community. All right? So I just wanted to show you all that. All right, again, we're done with that, Bill. Thank you, Bill. You're doing good. Round of applause for Bill. Thank you, Bill. You guys are good, I'm telling you. But in order to do tonight's program, we would like to thank with great appreciation QuestCore Pharmaceuticals for giving us the grant to do tonight's program. We cannot do our programs without pharmaceutical dollars, because just like Patricia cannot find somebody really, really wealthy to open up an MS clinic, we cannot get Bill Gates to fund our organization to do the programs that we do. And until we can find a benefactor who's going to just provide for us and make sure we could do all of our programs, we have to ask the pharmaceutical companies to give us grants to do our programs. So if you don't mind, I would like to thank them, and I hope that you all do too. In addition to QuestCore Pharmaceuticals, we also want to thank our other sponsors, Accorda Therapeutics. And by the way, Accorda makes Ampera. We want to thank Bayer Healthcare, who makes Betaseron. We want to thank Biogen IDEC, who makes a few of the different medications that Patricia just spoke about. They have Avonex, Tysabri, and Tecfidera, and are looking into many other things as well. Genzyme, a Sanofi company. Again, sponsors that we do need. Novartis and Teva Neuroscience, and all of they should be thanked as well for helping us to provide what we need to do to give you guys the programs. So I thank them. Patricia Pagnotta. She's going to speak with you all about emerging therapies, maybe a little bit about MRI, a little bit about symptom management, and then we'll get into Q&A. You ready to begin? Thank you, Tricia Pagnotta, for coming on down tonight. I like Patricia better. I do. You need this out of the way?
Sure.
Okay.
Okay, so hold on to your seats, I guess, because we're going to roll through a whole bunch of information very quickly. And Stuart's organization is appropriately titled Views and News. So what you're about to hear is some news with my views. So I am not being compensated by a pharmaceutical company to speak to you tonight, and this is not an FDA approved promotional program. I am going to ask that you hold your questions till the end so that everybody can have their questions answered, but you may hear things that you may not hear in a promotional program. This is information for you to use and maybe take back to your healthcare provider and ask questions, okay? Some of this, I just wanted to set the stage. So what we're talking about is multiple sclerosis. And multiple sclerosis, as many of you know, is a chronic, lifelong disease of the central nervous system that affects your brain, your spinal cord, and your optic nerves. It's damage to the myelin, which is the covering of the nerve, and that's what causes scars, and that's what we refer to as multiple sclerosis. So the nerve cell is actually made up of the neuron and the axon, and then you have that covering. I commonly tell persons this is as simple as the electrical cords running all around attached to me here. You have the one to the computer and then going to the electricity and whatnot. That's how simple it is. When things are not going well, then you would not be able to hear me, or you may not see the pictures that I have displayed here, and that's the problem in multiple sclerosis. So you have damage that occurs to that axon. We call it demyelination. Inflammation occurs, and that stripping occurs around the axon, and you get damage, get scars. That can be just damaged where you have some conduction, or it can be degenerative process where the axon is totally cut and then there's no communication to the next neuron. So that's what is occurring. So in multiple sclerosis, we manage multiple sclerosis by looking at three things: disease rate, as far as relapse rate, disability, and MRI activity. So those are the three markers that everyone should know about themselves. I always say there's some number 4, and that's adherence to drugs. But irregardless of whether you have a drug or not, you should know, have you had relapses? Are you being more disabled? And what is happening on your MRI? So when we look at MRIs, there are several different pictures that we look at. The T1 with gadolinium enhancement tells us about new things that are occurring. You can see on this picture here, there's a bright white spot. That is where the cells are being damaged, and because of that damage, the gadolinium was able to go in and light up when they do an MRI. So that is a new lesion. That's usually there less than 30 days, 30 days or less, and some lesions don't even enhance for a full 30 days. It can enhance the whole lesion, it can enhance part of the lesion. So, but if there is enhancement, that means there is active disease going on at that time. Your disease is still taking effect and still causing damage in your brain. Flare images are really good pictures for us to be able to show patients. I love to show patients flare images because they're the easiest images to see fluffy clouds. I guess everybody here lives in Florida. Fluffy clouds are beautiful, but they're not beautiful in your brain. So when you have lots of fluffy clouds in your brain, it can cloud your thinking. It can cloud your ability to be able to perform. The more fluffy clouds you have, that's what we call burden of disease. And so on your flare images, you would see these white spots. And typically, like you see on the picture here, they are around the ventricles and things. They're very classic lesions that we know are related to a demyelinating type of disease versus an ischemic type of disease like stroke. So we know how to look at these, but this is not a course on MRIs. So bright lesions that enhance are new. Fluffy clouds are white spots that are not enhancing, and typically they're older. But you can have a new fluffy cloud if compared to a previous MRI, it was not there. So that's new old. New is it's new and it's active and it's going, things are occurring, that's the gadolinium enhancing. New old means it's new since the last time you had an MRI. but it's not enhancing. Then when we look at T1 hypointensities, they're what we commonly refer to as black holes. They're areas where you have no neurons, no axons. You have really no brain tissue in that area. So you see on these MRIs, you see the nice little curves like kidneys sort of looking. That's your ventricles. That's where your cerebral spinal fluid lives. You should see some of that, but you should not see that in the middle of your brain. So when you see black holes in the middle of your brain, I refer to that as Swiss cheese. And I think I've got a fetish about food. Swiss cheese is not good. So you have to imagine that where you don't have brain, that is going to affect you. We know, those of us who see MS patients who practice routinely, we know that MRIs matter, that these lesions matter. If they don't matter at the time we see them, they will matter next year or the year after. They matter. So it's very concerning to us when we see new lesions, new old lesions, or we see lesions that are converting to black holes. And sometimes we'll see black holes that pop up and that was never a lesion there. That's very concerning. So we don't want to see any activity going on in your brain. That's one of those markers. We don't want to see activity happening in your brain. So, disease characteristics. I told you that this is a neurodegenerative disease. There's no cure for multiple sclerosis in the event that I had not told you that and you hadn't figured that out by now. There is not. We have not yet been smart enough, but we're working at that. So typically what happens in multiple sclerosis is you have inflammatory attacks. That's those relapses where you have symptoms. Inflammation is occurring most of the time, not all the time. Most of the time we can see that on MRI. We also know that there are things that are happening that we cannot see on an MRI. That's axons deep in your gray matter and sometimes deep in your white matter of your brain that we don't see what's going on, but we know it's happening. So early on in the disease, there's inflammation. We see that, or you're feeling that in relapses, disease, disability progression, and underlying that, there is damage, neurodegeneration that is occurring. Remember the picture of the scar versus the picture of the axon that doesn't communicate, that doesn't connect to the next neuron. So we know that that is happening all the time in persons who have multiple sclerosis. We would like persons to be free of disease activity. Wouldn't that be nice? Yes, that's our goal. When I see a patient, my goal is that they should be free of disease activity, and until they are, I'm not happy. So when I say free of disease activity, what does that mean? That means they have not had any relapses. So that's the clinical activity. I'm not seeing, they're not calling me, they're not telling me about new symptoms. They've had no relapses. Then I examine them, and they tell me about their life since the last time I met with them, and nothing has changed. They're still doing all the things that they want to do. They're still as productive as they were, and when I assess them, don't see anything different in the way that they perform in an examination for me. So that's free of clinical activity. Then we have to marry that with MRI activity. So we have to marry that with the other half. No more MRI activity. We don't want to see enhancing lesions. If we had enhancing lesions on the last MRI, the next MRI should not have enhancing lesions. We should not see new T2. We should not see clouds. We don't want them. We'd like to see them out in the sky here, but we don't want them in the brain. We don't want to see black holes. If we have those things, disability, relapse freedom, and MRI stability, then we have some assurance that a person may be free of disease activity. And at this moment in time, that's the best we can do. And so that's what we strive for. That's what I want everyone to reach up and say, that's what I want. I want to be free of disease activity. So there's ways that we go about trying to work on that for individuals. And historically, there was a way that I labeled this, and so I don't know that anybody would, call it this. But historically, what we had was an escalation type model, where a person came in, they had some attack, we diagnosed them with multiple sclerosis, we said, this is you, here's treatment we have, let's put you on this treatment, there's no cure for MS, go out, do well, and come back and see me. And hopefully you're being treated by an MS specialist who doesn't say, go out and live well and don't see me until you make an appointment. But on a regular visit, you come back, we see, has disease been suppressed? You're not telling me about relapses, I'm not seeing more disease activity. When I do my regular MRI, I'm not seeing anything. But if not, if those things aren't in check, then your disease is still active. And then I'm making another decision. So typically, in this model, you go from a person who's getting the lowest efficacy of drug with the lowest toxicity matched together, and then we go to the next one. Now, I have to tell you that of the the 10 disease-modifying therapies we have, many of them have about the same efficacy and about the same safety. So the platform therapies have about the same efficacy and about the same safety. We've been working with them for many years. But truly, historically, what persons would do is they'd go from one drug to next drug to next drug to next drug, and every time your disease is not stable, they'd go to the next drug. I said we have 10, count them, 10 disease-modifying therapies. How many persons in this room have had 10 relapses? Congratulations. So none of you have had 10 relapses. That's great. So therefore, you wouldn't, in this model, wouldn't have used up all the disease-modifying therapies. But if you can imagine a person who has been through 10 relapses, by the time we get to the most efficacious drug we believe we have, that may have more risk, then after 10 relapses, oh my goodness, that person may have enough disability that maybe they've thrown in the towel, and we're not even finding them after 10 relapses because they're not coming back. But so that's the model that we had in the past, and some people still look to now, is going from least and then just working their way up. Whoops, I went the wrong way. Okay, induction model. And so this is, again, another term that I've looked at in looking at individuals. We know that no two people with MS are the same. We know that people present many different ways. And so we should have the ability to then look at persons who we know in big groups are not all created equal. We all are created equal, and everybody should have an equal chance of having their disease cured to the best that we can. Disease freedom would be cure for right now. So if we see someone who worries us, we should have the ability to say, should I let this person go through 10 steps before I give them something that I feel is going to quiet down their disease, that I feel is going to be strong enough to shut their disease down so that they're not forever living with the disability that every relapse is going to cause them. Because whether or not you fully heal from a relapse, that relapse one day is going to talk to you because it's damaged to your central nervous system, and one day that is going to speak to you. So the goal, again, is not to have that happen. So there are a good number of us who will look at individuals and say, okay, you make me uncomfortable, and you make me uncomfortable for many reasons. So I look at individuals who make me uncomfortable, and I think about people who present with a lot of brain lesions, cord lesions, brainstem lesions. They're older. They're not white females, or they're older white females. So I look for the people that are the outliers in multiple sclerosis, and those people as a group have a higher risk of having more disability. And so that might be a person I would talk to right up front about, okay, I've got this really strong drug. It does come with some risk. Let's think about this, and maybe at some point we may decide the risks are not worth, and then go back to another drug that maybe has less efficacy, but we've already quieted down the disease, and then not subject them to the same amount of risk. So that's the thinking process that most of us go through when we're deciding on a disease-modifying drug. So the next slide, when it comes up, is going to talk to you about, if you weren't looking at those two models, what would be things that we should consider when making treatment decisions. You know, so definitely we should be thinking about tolerability, safety. You know, I tell persons I don't think about cost. It's not that I don't think about cost, but I think that there's enough help that if I want a person to get a drug, then that's not the first thing I think about. Well, we do need to think about pregnancy issues. We need to think about persons' lifestyles. We do need to think about mechanism of action. So this is the spiral if you would want to know all of the things that we think about and that you may want to think about when you're deciding with your healthcare provider on a disease-modifying therapy. I have to tell you in the room, again, this is views and news. If you walk into a healthcare provider's office and they present you with all these drugs and tell you have multiple sclerosis, I want my patients to be involved in making this decision. But it is not a decision that is made solely and independently by a patient. So if a healthcare provider solely independently asks you to make that decision, you may think about that. What I think about is those of us who know and keep up. We know about these drugs enough to know what's going to happen in the future, and we have opinions, and we usually share those opinions. So you should be with someone who's willing to work with you, not control you, work with you, but give an opinion. Okay, so now that was setting the stage. Now we're going to talk about some new and emerging things, and we're going to run through a lot of stuff that's going to be very fast, and I don't expect you to remember all of this. Again, this is tidbits for you to talk to your healthcare providers about. Okay, Tysabri. Tysabri's not new. Tysabri is not new. It's been out for a while. It's been out. It's been taken off the market, and it's come back. It is, in my opinion, the strongest FDA-approved drug we have right now. I'm very pleased to tell you that it's now been approved by the FDA that we can use it first line. So many of us, have used it first line in that right patient. But now the FDA acknowledges, yes, there is that right patient, and that right patient has the right to have a therapy that will be effective for them if, in combination with their healthcare provider, they're willing to take that risk. So that means we could use this drug for newly diagnosed. We could use it for persons who are not yet on therapy. We could use it for persons who have more active disease. Or we can use it for persons who have poor prognostic indicators, but it does not need to be a second-line therapy any longer. We also, those of us who prescribe Tysabri are very well aware, and anyone who's receiving Tysabri, about the TOUCH program. I personally love the TOUCH program because what the TOUCH program has done for us is help us understand Tysabri so much more. They've developed the JC antibody. Before the TOUCH program, we had no clue what caused whether persons, what their risk of was getting PML. PML is that brain infection you can get with Tysabri. Well, through the TOUCH program, Biogen developed a JC antibody test. So we know whether or not a person has been exposed to this virus. And we know, we used to think everybody had been exposed to this virus. Well, we know now that not everybody has been exposed to the virus. So we have that from the TOUCH program. We also have something that you will not be able to hear from Biogen that I'm about to tell you about. It's not approved for promotion. It's not approved by the FDA. But the TOUCH program, we have data called index values. Index value is on an individual who is JC positive. We get from that lab another number. That number tells us with some certainty, again, it's only the persons that are enrolled in the TOUCH program that this has been studied, so that's the some certainty. The data is limited to persons who have been on Tysabri. But with some certainty, we then know what a person's risk, other than just being positive, for the JC virus is. And through that data, we know some persons who are positive and have index values less than 1.5, actually some of those people have much less risk of coming down with PML than what the product label says, that the FDA says you can. So we know that. So that gives us more data to be able to talk to someone and make an informed decision about what their risk of staying on that drug is. So we use that. We also can use it on the flip side. So the flip side is, okay, we all know if you're on Tysabri, it's the number of infusions you've gotten, and it's whether you've had prior immunosuppressant therapy, and if you're JC positive or not. Well, that's all we had. So some people thought, oh my, after 2 years, JC positive, everybody had to come off of the drug. Well, no, this index gives us more data about that, but it also gives us data that, okay, if you're after 2 years and your index is high, well then yes. I don't know about that person, but if, depending upon the index, I would not be willing to take that risk for the individual. So it gives me more certainty to be able to say to a person, your risk is really high right now, and we probably should think about maybe going to another therapy that will be less risky and possibly just as efficacious. So the other good news about this whole data that has happened is that persons who are not JC detected, wonderful news for them. Because I tell everybody, I have no clue how you get the JC virus. I don't know. I don't know if the tea that you're drinking tonight has it. I don't know if where the air we're breathing has it. We don't know. None of us have been smart enough to figure that out. But Biogen has now been able to share with me, if you're JC negative, not detected, you have an 87% chance of never converting to being JC positive. So does that mean I will not test persons on a regular basis? No. I'm still going to test persons on a regular basis, and for me it's a minimum of every 6 months. But I have an 87% chance of the fact that if somebody's negative, they're always going to be negative, and that's wonderful. That is good news. The other thing is, so persons that convert, there's a very few people that convert. But of those persons that do convert that were initially negative, 2/3 of those individuals will always maintain an index value that is lower than what would call them, what the PI says that the risk of getting PML is. So that's more good news too. So that's all thanks to the TOUCH program. So Copaxone. Copaxone, is that new? No. Copaxone has been out for a very long time. But they did a GALA study, and the GALA study is looking at Copaxone 3 times a week. And so they randomized persons to either placebo or Copaxone. And so this was, we've got to give people that were in this trial a lot of kudos. Again, going in a placebo-controlled trial is rough. But through this, they were able to show that there was significant annualized relapse rate reduction. There was significant MRI reduction. And so the Copaxone 40 milligrams 3 times a week is as efficacious as Copaxone 7 days a week. So if you would like to be able to take Copaxone 3 times a week, you can get a Copaxone and have assurance that the Copaxone that you would get 3 times a week is going to be just as efficacious as the Copaxone that you're taking 7 days a week. It also gives us treatment options. So when we're talking to persons, there's a good number of people, when I would tell them about this wonderful drug, 7 days a week, I have to inject myself 7 days a week, and they're also coming saying, oh, there's oral therapies, and you're telling me about a 7-day-a-week drug injection? So the GALA study also showed the adverse events were not significantly different than what we knew about Copaxone normal, the 7-day-a-week Copaxone. There were fewer injection site problems. Obviously, you're giving less injections. There were fewer injection site problems. There were fewer post-injection reactions. The same post-injection reaction you can get from Copaxone now, well, again, it's the percentage thing. If you're giving less injections, you're going to have less percentage of getting that post-injection reaction. So again, the Copaxone 3 times a week is the same as the 7-day-a-week drug. So, advance. Avonex. Anybody thinks Avonex is new? No, it's been out forever. Well, I want to point out very clearly to those people that are looking at this slide, I appreciate those of you who look at the details that I put up on the screen. I put in a 3rd column here that says interferon IM Q week pivotal. Please understand that that is extrapolated data from a previous trial of the very first trial that Avonex did to come to market. So that is not the same patients that were in this trial, and so there would be difficulty if I was standing up here in a medical conference and was sharing with persons. They would say, well, but those weren't the same patients. They weren't randomized the same way. They weren't done at the same time. I just want to give you some data to think about. So this is pegylated Avonex. Pegylated Avonex means it's mixed with this special modulator that it will last longer. So it gets to its Cmax in an adequate amount of time, and it stays in your system longer. So it's like taking an extended release medication versus a short acting. And so the advanced study looked at pegylated Avonex twice a month versus 1 time a month. So every 2 weeks versus every 4 weeks. The data is up here. Again, we're not supposed to compare trial to trial. These are different persons, but clearly the twice a month drug is as efficacious, if not potentially a little more efficacious, but again, different trials, than regular Avonex. This is before the FDA now. I believe that pegylated Avonex, we are hoping that will be out by summer. So by summer, persons who are on Avonex, they will be able to most likely take their injections twice a month, every 2 weeks. And so it's an interferon, And so similar to other interferons, so I imagine that that will help our persons who are on interferons also. We didn't see anything surprising in this trial either. So all the same side effects. The only different side effects was injection site reactions. We very rarely see injection site reactions with Avonex now because it's an IM injection. The pegylated will be a sub-Q injection, so there are going to be a few injection site reactions that we didn't see with Avonex. All right. Gilenya, fingolimod, that's not new either. And I really was not going to talk about Gilenya at all, but I felt obligated I needed to put this pill up here. I want you to know that this is not a new drug. It's been out for 4 years now. There's nothing new happening, but they are going back and looking at data that is not being mined, data that was planned, data collections, and they're sharing that with the FDA now in an effort to try to get a label change. And so I'm sharing that with you. What they're saying is that they are the first drug that can prove that they will reduce brain atrophy. I can stand up here and tell you that brain atrophy makes a difference. Brain atrophy does lead to cognitive problems in MS, we know that. So if you can get a highly effective medication and it can reduce brain atrophy, and we can figure out the meaning of that. And what I can stand up here and tell you is we really are having difficulty as a medical team trying to figure out the meaning of that because we haven't been able to measure it well, but we know it matters. So a drug that can reduce brain atrophy is important. You see here the green lines for you are healthy controls. So they did MRIs of healthy individuals. There's a comparator with Avonex here. And so the high dose Gilenya that is not FDA approved did better in some forms than the FDA approved, but the FDA approved drug, the 0.5 milligrams daily, was no lightweight, did a significant in controlling and reducing brain atrophy. This next slide here shows you that, again, it was a drug that compared itself to Avonex. In those persons in the trial that were compared to Avonex, after 1 year, they had the ability to switch to active drug, which was fingolimod. Those persons who switched to active drug after being on Avonex for 1 year then quickly started demonstrating decreased brain atrophy. So this drug definitely is a good drug. It's definitely in my armamentarium of drugs that I use for individuals. And they've marked this brain atrophy out 4.5 years, and they still have an extension study. So I think that Novartis is going to be leading the way in helping us understand brain atrophy. So there are some new drugs, and many of you may have heard about these, so we're going to fly through these, Aubagio and Tecfidera. Aubagio, which is teriflunomide, was approved in 2012. It has a unique mechanism of action in that it suppresses T and B cells, and it does this differently. It does have some safety concerns, and none of which I find unable to manage, but pharyngitis is in a lot of the drugs. Alopecia, which is hair loss. Most people get very concerned about that when I talk about that, and it's really, I feel like they should be in the shower with me every day. It's just a little thinning of the hair. And it usually, once the Aubagio is saturated, that goes away. So it's not something that this is not like taking chemotherapy and you go bald. This is just a little hair loss. The biggest issue is liver enzymes. We do need to monitor person's liver enzymes. But it's pretty efficacious. It has an annualized reduction against placebo, and it had 2 arms, a 7 and 14 milligram arm, so there is the ability for providers to make a decision. The 7 and 14 did not do different in annualized relapses. They separated out when it came to disability. The 7 milligram did not demonstrate clinically significant disability. So if you want disability to be reduced, you have to be on the 14 milligrams. But oftentimes providers that are using the 7 milligrams are just trying to get persons to get through the liver enzyme problem. It did well on MRI lesions as far as unique and new lesions. It reduced MRI lesions on the 14 milligram, the 69.4. And so it was definitely in the running there. So here again in another study, all the oral studies are huge studies. Everybody just came out of the woodwork to be an oral study. So, one thing I can tell you is about any oral drug, it's got minimally 3 times the amount of individuals coming out of trial that any of the pivotal drugs did. So, good data. And again, this supports that the 14 milligram was a much better drug as far as all around. It had disability reduction that was clinically significant, and the annualized reduction of relapse rates. And so persons think about this drug, and they've heard me say, I put the side effects up here for you to look at while I say this, that teriflunomide, Aubagio, does not have a robust difference from our platform therapies as far as the numbers. What it has is a unique mechanism of action. And so that unique mechanism of action that the other platform therapies that may perform as well as this drug, this may be a drug that works for someone. So it's definitely got a place in the market. It does have the ability, the one nice thing, it has a long half-life, it stays in the body for a very long time. But if we want to wash someone out, we can in 11 days. BG12, dimethylfumarate, which is Tecfidera. It's another oral agent. It's got a nice short half-life, which is a wonderful thing when we think about drugs. We like that because it gives us better feeling that if we needed to get rid of the drug, we could. But it does mean that it has to be taken twice a day. And it's got a very unique mechanism of action, changing, it's an immunomodulatory drug, changing from the inflammatory to the anti-inflammatory shift. It decreases the circulating T cells. It activates this NRF2 pathway. Let me take a moment right now to say, I have heard a lot of people ask me about this thing called Protandim. They're not the same. So if you think that Protandim and BG12 have anything alike, go back to and talk to me about that later. There's nothing alike, and so I've heard people ask me about that. So in a trial the confirmed trial BG12, this compared itself to Copaxone. I cannot explain why Biogen made the decision not to go full force and try to outperform Copaxone. They were definitely outperforming Copaxone, but did not power the study with enough data to be able to take to the FDA and say, oh, we are so much better. So we can't say that as far as in promotional, but definitely it looked like it was outperforming Copaxone. You can see here the reduction in relapse rates were significant, higher than platform therapies. And when we go to the DEFINE study, which was just placebo compared to Tecfidera, definitely really robust reduction in relapse rates, 53% compared to placebo, so good. MRI activity, phenomenal MRI activity, 90% reduction in gadolinium enhancing lesions and new T2 lesions, and 85%, so definitely works very well in the MRI arena. Has some side effects, and this makes us look very busy. The only thing that we have to work for as far as BG12, Tecfidera, is the FDA says we need to watch persons' lymphocytes within a year. But there's some other things. You can have flushing, you can have GI side effects. You need to anticipate that. It only happens in about 30 to 40% of persons, but when it happens to you, oh, it happens. And so we can modulate that, we can help with that, but that is a known side effect. Okay, so I'm getting the heads up back here. Oralizumab, this is another drug. This is a drug that will be going to the FDA before the end of the year. It is a very powerful B-cell targeted agent that has a long effect. In studies looking at this, persons that were in 96 weeks, there were better than 65% of individuals that stayed disease-free. This has a place in the market if the FDA approves it. So it's a very powerful drug, has some side effects. It's an infusion. The biggest reaction was infusion reactions, but we did not see anything terribly significant after that. It did reduce some brain volume as far as atrophy, but not like Gilenya. The most significant was there was the infusion reaction. There were some infections that occurred, but nothing that was not manageable. There was one individual who did die of another immune reaction, but again, I think this drug has a place in the market, and maybe by the end of the year we'll see that. Stem cells, I just want you to see a picture of the fact that what they have to do stem cells. They have to take them out of your body, they have to give you chemotherapy, they have to wipe out your immune system and then give you stem cells back. So is it the stem cells that are working, or is it the fact we wiped out your immune system? We're still trying to answer that question. So the two symptoms I'm going to talk about is weakness and fatigue. And weakness, it's all about geography. Again, the monopoly board. Where are your lesions? Primary weakness is looking at the weakness that is caused from multiple sclerosis, the weakness that is caused because of those scars up in your brain. And so when we look at primary weakness, we look at things like relapses. You know, persons during a relapse are weak. Then we look at chronic weakness, the weakness from the disability that happens from the lesions that you have in the brain. So the analogy here is you can put a new light bulb in all you want, but if the fuse doesn't work, the light bulb isn't going to go on. So primary weakness we may have to work with. How you avoid primary weakness? You avoid not treating your disease. Secondary weakness is that which is related to anything that is not technically part of MS. So deconditioning. Persons that, you know, when you have MS and you have a better chance of becoming deconditioned if you stay sedentary. So we want persons to exercise. We want people to stay together. People that don't eat well, don't rest. Chronic pain can lead to medications and different things that cause secondary weakness. Anxiety, depression, it causes a lot of weakness. And then there are other things that can give you the feeling of weakness. So there are other medical conditions, hypothyroidism, anemia, other illnesses, diabetes, heart disease. So really, weakness can be a problem, and we need to look at that very multifaceted. So conquering weakness, first and foremost, manage your disease progression. Don't get weak in the first place. Once you have that occur, well then it needs a collaborative team. The only drug I know now that we can use to definitely improve weakness beyond other symptom management drugs that we use for things like spasticity is Ampera. Ampera is the walking drug. And I can tell you, I've been asked several times about this drug. Yes, it improves people's walking. What it does is it helps the communication from the neuron to the next neuron. It helps persons walk. It doesn't work for everyone. I've seen people it does not work for. But guess what? In the people it does work for, I have seen it work for more than walking. So I can only prescribe it for walking, but there's a good chance if you're a responder that it may help more than walking, and it definitely helps weakness. And so that is the FDA approved drug for walking, and I use it for walking and other things. I can only prescribe it for walking. Fatigue. It's the most common and most disabling symptom of multiple sclerosis. This is what takes people out of the workforce. This can happen at any point in the disease. It can happen before the disease is even apparent. Oftentimes, when I'm seeing a person who's coming in, the thing that they keep talking about is, I'm tired, I'm tired, I'm tired. So oftentimes, that is part of the symptom. That's not what they're coming to tell me about, but the recurring theme is tired, tired. But the fatigue that is classic of MS fatigue is that comes along without any warning. It's a sudden attack of feeling just drained, like somebody just hit you with a Mack truck and you can't move. And it makes all of your symptoms worse. It definitely can ruin your productivity and cause you problems. And other things, again, it can cause the sense of tiredness, lack of energy, feeling exhausted, feeling more disabled, motor weakness, cognitive problems. We know we don't fully understand this. It's very multifaceted, and so again, the issue of fatigue is to work with your healthcare provider and be open to the fact that, okay, it might be more than MS, and we might need to do multiple things to make this fatigue better. We may need to look at medicines. We may need to curb this down. And guess what? The best management for fatigue is actually moving. So move more, and you'll be less fatigued. All right, so fatigue management, again, it's a rehab approach. We need to look at other secondary things. We need to make sure that there's no other medical problems. When people come in and tell me they're so dramatically fatigued, oh, that could be a relapse. It could be disease progression. But MS is still a rare disease. So I cannot say fatigue is common in MS, and I'm not going to look for anything else. I need to look for those other things, and when I've ruled out those other things, I can really start making sure I'm dealing with all the MS things. Okay, I think I wrapped up in my 40 minutes. I am going to be here through the whole program, so I am going to be available to ask and answer questions, and thank you, Stu, for letting me talk.
Thank you for coming here. Now, without getting too crazy on me talking again, because I could do this all night, with or without a microphone, all right? But our next guest, Justin Koenitzer, is a psychologist, and Justin works in this area. And Justin's a very good speaker, and some of you may have heard him before, because we've had him in a few other programs, but if not, I would like you all to say thanks for him coming down here tonight as well.
Well, thanks for having me, and it's hard to speak after Tricia there. She was full of so much information, so I hope you got something of usefulness there. I'm sure you got a lot of things. I'm coming here tonight to talk about a little bit different topic, to spread out your knowledge base tonight. The issue of MS and the impact of MS on the family. I'll talk a little bit about cognitive issues that Tricia left off for me to address, but mainly I'll be talking about the impact of MS on the family. But before I even get in, just real quick, can we do a show of hands of how many people have heard this talk either with me or someone else before, something similar? Okay. Last night? Okay. So no one else. Oh, excellent. Okay, because I hate to be redundant and I would tweak it for your needs, but no one else. So excellent. So this will be good. Before I get started, let me go back and just say I'm real happy that Stuart asked me to talk, because I am a clinical psychologist and I can speak about some of my therapy experiences and what I've come to know about working with chronic illness and persons and their families dealing with it. But also my background's in neuropsychology, and so fortunately I've done some assessments and work with people from a different aspect as well with MS, and I think that I understand from a neurological standpoint perhaps a little bit better than the average psychologist might about what you and your families might be going through. Okay, so I hope to bring that to you when I talk. So this I'll skip through. I put a little bit in here, but you've already talked about that. Tricia did an excellent job showing the neuron and talking about what MS is all about. It's a demyelination process. So it's like that wire that gets its loss of its outer coating, and the information that goes between your nerves and your brain tends to slow down without that coating, that protective coating. Okay, we talked about flare-ups already, and there's just some statistics for you that I'm guessing most of the audience knows or can look up online. MS starts with an individual. So we'll start there and we'll zoom out to the family, okay? And I'm going to run through maybe 5 minutes of what it's like as an individual, some emotional and cognitive symptoms that are common in MS in an individual with MS. The reason I want to do this, and Stuart had asked me to leave off some of my talk that I usually do so it's not as redundant and to keep in the timing of things, but I like to do a little bit of the individual because as you'll see, when you're an individual dealing with your symptoms, you feel like an individual with your symptoms, and it's only in understanding you as an individual first that we can begin to understand how you interact with family members. So we'll zoom into this middle area, and I think I have the red pointer, so you can follow me as you're getting tired post-dinner here. You can just follow my lead, okay? We're going to zoom right into the individual and talk about impacts, cognitive and emotional. Do y'all know what cognitive means? I don't want to condescend here at all, but we throw out some terms sometimes. We assume everyone means. Cognitive is just a fancy word for thinking skills. And when I use the expression thinking skills, I mean attention, concentration, memory, okay, any skill that you would use your brain for. One of the biggest points about cognitive symptoms in MS in the individual is they vary considerably. It's one of the most heterogeneous presentations in neurological disorders I know. Okay, so John, Sally, Bill, you could all be in the same age, same stage of disease, same subtype of MS, and have completely different symptom presentations. And that's so important as you join support groups or talk to friends or talk to other people to understand that what is for them is not necessarily for you and may never be. And Tricia did a nice job explaining that one of the reasons is depending on where your lesions and your flare-ups occur in the brain, will give rise to different symptoms. And as they migrate and change over time, you're going to have different symptom expressions. So that's one of the main reasons there. Memory is one of the most common cognitive symptoms that folks with MS complain of. So I imagine some of you out there shaking your head, I can see, that you feel like your memory is failing you at times. Fatigue, yeah, I know, I hear you, I know. Fatigue, Tricia spoke to already, is also very common. I know that experience. Just some statistics real quick here. Let's look at these. 30 to 50% of people, I'm going to take this off because I like to walk around a little bit, if I can. Okay, 30 to 50% of people will develop memory or cognitive impairment, okay? And I talked last night, this is looking at, I think, 10 to 15 different studies, and they're relatively recent. 2011, 2012 is when I did my lit search. So these are statistics averaged across those studies. That's a lot of people, right? 20 to 30% more will develop significant memory or thinking skill impairments with MS across the lifetime of their condition. But the cool statistic that I want to highlight is, I'm going backwards, is that in these papers, we always find a proportion of people, 20 to 50, depending on where you read, of folks that will not develop significant cognitive symptoms. And we have to remember that. We're hearing everything about our memory problems. You're shaking your head. We're tired. And I'm not going to pretend like MS is fun. But I do want you to begin to shift your perspective when I ask you to look for the positive things in your life. Remember that the literature also shows us that some people do not ever develop significant cognitive symptoms, and some of you will meander into mild impairment at times, but otherwise be symptom-free in terms of cognitive symptoms. Okay, other motor and cognitive symptoms, again, very quickly, only the ones Tricia didn't address, just so I can connect with you. You can read, I presume. We talk about this. This becomes very impactful when we're talking about social engagement and engagement in families. This dysarthria or slurred speech that comes and goes. Okay, that's kind of embarrassing, so that has important emotional implications. Incontinence, obviously, can be an issue, and then you see my less common symptoms down there. I put those down there because newly diagnosed, and particularly younger people I've saw in treatment, are so anxious and worried that tomorrow morning they will wake up and be incontinent and be in a wheelchair for the rest of their life at age 22, that symptom, that anxiety, begins to impact their life like you wouldn't believe. And I want to show you that that's a less common symptom. If we had someone walk through here right now and not know what we're talking about, someone from another salon and come through and look around, would they know you have MS? Nah, you're a good-looking crew, okay? So we're not all going to develop seizures, vertigo, and those kinds of symptoms. Emotional impacts on the individual. My little child in the dark room slide is an important one. And you're done eating, so I don't hear anything clanging. You're all listening. So listen to me here, and I need your input. What is the number one fear in human beings? It's not public speaking. And we'll cut the age group in half. We'll say folks under 50. No, we'll zoom in. We'll say folks under 12. 0 to 12. What's the number one fear in kids? And raise your hand because I see someone in the back. Yes. I can hear you. Yeah.
Social ostracization.
That's an excellent one. I think that's number 2. With all this bullying that we have nowadays. Social, yes, ostracization. I'm thinking of another one. I'm sorry? Abandonment. Boy, you guys are psychologists in the making because you're looking at this picture of a little kid in a bed and we've got abandonment, social ostracization. Let the picture guide you. Yeah, afraid of the dark, right? Okay. All right. But good answers. Good answers. We'll come back to them. So my next question, the follow-up is, why are we, I'm going to say we, afraid of the dark? Yes, because it's obvious, right? Because we don't know what's happening in the dark, right? So follow me for a minute, and then we'll talk about the monster. Thank you, Stuart. Right, the poem. So it's not that when I use the word monster, I'm thinking of a little kid thinking about a monster in the closet. The fear is really not toward a specific object. This is so interesting. And for those of you who have kids or you have grandkids and you want to work with this concept for a minute, this is important to you in your MS, so listen close. The fear is not necessarily about a specific object always, not about the monster in the closet or about what a kid might say to you at school. Those are other kind of fears, complicated ones. More importantly, deep down inside of us, we all have a fear of the unknown. When you transition to a new job or when you're newly diagnosed with MS, it's not that necessarily in the beginning that you're afraid of the wheelchair or this or that. It's that you're afraid that you don't know what's going to happen or what could happen to you, and could it be the wheelchair? But the real fear is that uncertainty of not knowing what's going to happen to you, okay? And that is one of the biggest emotional impacts of MS on individual people with the diagnosis is the fear of the unknown. What are they going to encounter? And so we talk about depression being up there, but I always put anxiety first. Anxiety is fear or uncertainty, okay? Because I think that precedes depression in many chronic illnesses and possibly even in MS. There is so much uncertainty. Depression is also common. I've seen estimates of higher than this, but let's say 25% of folks with MS will develop a depression. And I always highlight this part here. If you can read this, it says there are 2 main types. One is a reactive depression, and one is a depression that's the direct physiological consequence of the lesions in your brain. Important to distinguish the two. Maybe academically for you it doesn't matter. But what I mean there is as lesions emerge, if they emerge sort of a little bit more lower in the brain, the lesions themselves can impact nerve cells that we find are related to emotional centers in the brain and may bring on a depression from the lesion. The other type, the reactive type, is the type of depression when you start to recognize some of your limitations from MS, you begin to react to those limitations and get sad, right? And worry. And then the depression develops from there. All right. The reason that's important, by the way, I don't always explain it, I see some recognition out there, is because if you're suddenly overcome with emotion and you're a positive thinker, and you have good support, and you don't feel like you're reacting to your condition with anything other than optimism, then I want you to recognize you still may feel down at times, depending on your flare-ups and your fatigue and other physical symptoms. And that's okay. And lastly, euphoria. I'll be quick here. It's an interesting emotional consequence to an individual. It does happen in MS. It's an odd one. Euphoria is that feeling of feeling really good. And it's actually, in clinical psychology, a negative symptom in the sense that you feel so good you're almost uncomfortable. In younger generations, I don't know, I see some younger folks out there, but middle-aged and a little bit older, I don't know if you know this analogy, but I talk about drinking an energy drink. Hey, today we have rock stars and monster drinks. If you drink one of those energy drinks real quick, a lot of times people will present to the ER complaining of heart palpitations. They feel so hyper and so awake cognitively that they're uncomfortable in their own skin. And sometimes euphoria can be felt that way. So I always wonder, if you're comfortable raising your hand, how many people have experienced extreme euphoria they believe is a consequence of their MS? Anyone yet? Okay, then we'll skip it. You may. The quote that I love of a person with it is someone who is literally bedridden says, "Doctor, you will not believe me when I say I feel thundering well." Physically bedridden, feeling thunderingly well. That's that euphoria. And then the other emotions to keep in mind are anything related to the sense of loss. Just like when someone passes away that you love. We have grief, fear, anger, denial. All those emotions packed tightly into one because a lot of people begin to feel like they're losing their self. This was old self, this was old me, now I have MS, I kind of wear it as a badge, and it's not who I used to be, and I'm losing that person. So this is obvious, most of it, okay? That's you as an individual, perhaps, or the average person. So let's talk now about how that person with MS and those common cognitive and emotional symptoms fits in the larger network of their life. All of these areas, I'd love one day to have a longer panel and zoom in and address them because I think it might be important. But the second most important area, I believe, for you all is your family life, family and social life with your friends. So let's zoom in to the impact of MS on that dynamic. And as we do that, I want you to imagine I use two different analogies. One's the spider web, and I use another one just the other day, the trampoline, and I'm going to try that one tonight. Okay? So imagine a really large trampoline, and you and your family, your closest friends maybe, are all on that trampoline. Okay? I see round tables, trampolines are round. So get all 5, 6 of you on there. If you want to have a beer in your hand and good music on, fine. Whatever you do in your mind right now is good. You're all on that trampoline having fun, okay? And you're tired from bouncing around. And so you sit down on the trampoline for a minute. And I keep looking over here at this gentleman because he's very interactive with our crowd tonight. And you're taller than most of your people, so you fit good with this analogy. I hope I can use you. So this gentleman and his trampoline and his family and friends, they're there. And he decides to get up and start bouncing. You're all sitting down, relaxing, resting. What's going to happen to everybody else on the trampoline? They're going to bounce up, right? Whether they want to or not, okay? So keep that picture in your mind because here's the deal with families. It's a very hard concept to talk about that mental health psychologists and also medical providers understand this. Everything is linked in families. That's why we use the word family dynamic. Okay, so like a spider web or a trampoline, what one person does in a family unit necessarily affects every other individual in that unit. And the best way to remember that is to think about the trampoline. When one person jumps up, you can't help it whether you want to or not. You're going to be affected. You're going to feel the ripple. You're going to bounce. So right there, period, I'm done. If I walk away, we all get the sense that all those cognitive and emotional symptoms that you may be going through as an individual with MS are going to be felt and experienced by everybody else in your network. Chronic illness are not diseases of the individual, but rather diseases within a family. What are some of the things that we need to consider about MS in the family? The first thing, again, quite complicated actually, is the idea that all of you bring your families to the table before your MS. Okay, diagnosis age 20 to 40, typical for initial diagnosis or onset of symptoms. You already have your family before you're 20, I hope. Okay? And so whatever dynamic is going on that trampoline before your MS is there and going to continue to be there. Sister doesn't like brother. Brother stole this from other brother. Mom favors this sister over you. Okay, all that stuff is already there. Now, enter MS in the picture, and what do we got, right? So you get it. So we have pre-existing underlying difficulties can be exacerbated by MS. Imagine whatever complications you have in your family, now just add a stressor that a newly diagnosed MS brings to it, and those things are going to get exacerbated or enhanced. A big one for any age, newly diagnosed, not newly, someone who's been struggling for a while, role shifts. I want you to think about this. What are your roles in your family now, both patient with MS, or person with MS, I should say, and caregivers? What are your roles? And how, as you navigate the challenges of multiple sclerosis, will those roles possibly shift? We zoom into the physical aspect alone in our minds here for a minute. Maybe someone needs to start doing the laundry, or someone can't keep up with a certain physical role, so you shift. How is that going to affect you and your family? Are you going to be able to manage it? Going back a little bit, will you even talk about that? I'm doing some of the talking here for you, and my hope is always that you'll go home and you'll chit-chat on the drive home. Oh, Tricia was a great speaker. That other guy, I don't want to talk about that stuff. I don't want to talk about that feelings. But maybe you'll talk about it and you say, we've never had a conversation about what we might do going forward in terms of role shifting. Would you like me to take on this? Do you feel like you can handle it? I'd be happy to. Okay? So I encourage you to think about what kind of roles might shift in your family. Another big one, caregiver stress and caregiver burden. It's a funny term when I first learned it in graduate school called burnout, because it is as it sounds. And then I'm reading the medical literature and I'm seeing burnout and I'm thinking, this isn't a medical term. I'm here to learn medical terms. They actually use the term because it gets at the idea the best. It's called burnout because that's what happens. Caregivers are so extremely vulnerable to burnout, meaning they get tired themselves because they have a lot of duties placed on them. We could ignore it and say, well, that's what you signed up for, or that's part of the role of caregiving, or we could be smart about it and say, since we know that this is a phenomenon that happens time and time again in families, let's address it. And my call for you tonight is, if you haven't heard of this or you're feeling it and you haven't done anything about it, listen to me, and maybe now is a time to bring forth to your medical provider, hey, I think I'm feeling burnout from caregiving. What resources do you have for me that can help me with that? And there are a plethora of caregiver resources, okay? Both through Stewart's site, in terms of psychoeducation or just education, and through your own providers that you're comfortable with in terms of getting help and resources for caregiver burnout. It's hugely important. If the caregiver burns out or becomes depressed, him or herself, what happens to the person they're caregiving? You got it. 50% of individuals in most studies with MS are dependent on help from a close relative. And not to scare you, I don't mean as you develop completely dependent. I mean dependent in some way. They need some type of help. So there's a lot of caregivers out there. To really hammer home the point, I'm a visual person, so I like this image. We've all seen these signs, I think, where they have a concept underneath and a picture that captures it. Okay, this is a simple one. A pep rally, right? Teamwork. But this picture to me is a little different, and let me just walk you through what I mean. So over here, if you focus on the left, you've got the boy in the red shirt and maybe his brother. He's playing video games in the mall, and he's using his brother because there's no chair there. His brother's, hey, I'll get down on my hands and knees. So let's say this is the person with MS in the analogy, and this is the caregiver. Sit on me, I will help. I'll ease your burden, right? But then if he sits for too long, he's going to get tired real quick. And how dare I ask you in the audience who are struggling perhaps with your MS to listen to this next thing? How dare I? But I'm going to. You can be angry with me later. Okay? I'm going to ask that if the caregiver gets tired, consider allowing them to sit on you. Am I doing something wrong over there? Oh, okay. Right. Now, do I literally mean while you're in the throes of your enhancing lesions and new flare-ups and fatigue that I want you to get down on all fours and let your caregiver jump up and down on you? No. What I mean is, remember, when things get tough, in times of frustration or when someone's burning out and they're bringing that to your attention, yes, you are entitled as someone with MS to feel your symptoms and ask for support. But please just recognize that your caregivers are doing the best they can for you too, and they may need support. Okay? Just recognize that is really what I'm asking you to do. Psychology is a weird place. Some people think of us as complete optimists all the time talking positivity. I'm not one of those people, unfortunately. I'm a realist because I think being real gets you closer to happiness than just pretending like everything is hunky-dory all the time. Okay? And so as a realist, I want to tell you that people with bona fide, legitimate conditions, chronic illness conditions, sometimes fall into roles themselves of needing to be given care. And I'm not saying you're lying or not feeling good, but we just fall into these roles. And what I'm asking you to do is just recognize that your caregivers may also need some support. So some more impacts on the family. Emotion related to loss in some or all. This is interesting. We talk about the individual has feelings of loss, grief, anger, denial. But just like the ripple effect through that trampoline, other members in the family could also feel loss when the person who they look up to, perhaps grandpa or grandma, has MS and can't do the things they once could. Maybe your role has shifted. Your parents always took care of you, and now you're taking care of one of your parents. And you look up to that parent, and they're the strong one, and they're the rock in the family, right? And so now their individual loss may become your family's sense of loss, like, wow, I really feel like they're kind of gone. They're not the person they used to be. That's a real feeling. It's a real experience. MS symptoms or the changes they cause in family dynamics can create barriers to intimacy, joy, and all these other areas of your social life. Okay? And again, as a realist, I like that it gets a little somber when I do this part of the talk. Not because I think it's depressing or that you should walk out of here, but that I think we need to talk about this stuff and recognize it as truth, right? You guys know that. Because the only way to get the intimacy back into your life is to recognize first that it may be fading for some reason. Then we recognize it, and we're honest and open, and we go figure out how to get it back. And then we're going to win, as opposed to pretending like it's not an issue with us. Okay? And lastly, I'll be brief on this point. I'm just about at the edge of my time here. I don't see anyone under 16 in the room tonight. Thankfully, you've all read your registration forms, okay? But for those of you with grandkids or those of you newly diagnosed who are younger with younger children, there's a lot in the literature about children and their perspective on MS in a parent, that they may be embarrassed when mom or dad starts to walk a little differently or talk a little differently. And this is obviously an area that may be cause for some heartbreak in you as a person with MS, but again, it's an area that means we need to address it and talk about it and think about it, okay? We had a talk last night and an important point got brought up and I just want to bring it to your attention. This applies not only to kids, I've worked with kids like this, but also to adults. Someone was talking about the concept of resiliency. And although I bring these concerns to your attention, it's also nice to highlight the positive aspects of the situation too, and that is anyone, a kid or an adult, who has to overcome an obstacle and who has to constantly think creatively about solutions to managing symptoms or dealing with stress or coping, guess what you get out of that? Stuart's going to give you, what's tonight in the raffle? A DVD? A DVD player. So Stuart's got a DVD player that you're going to get out of your suffering through our talks. But for suffering through some of the ups and downs of your condition, what do you get out of it? You get resiliency. You get a stronger sense of self. You get a sense of control. You get a sense of wisdom that you can bequeath to the people who come after you. I've lived through this. I've done this. I can handle this and teach you maybe how to handle other things in your life. What do you do to get there in 3 minutes? Well, start with focusing on what you can do as opposed to what you can't. Easier said than done, right? Bring this into your car tonight on your way home. Talk about this. Because everybody in here can do a lot of stuff. I sat in the back and watched all of you. I know you're capable of doing stuff, asking good questions, smiling, laughing, engaging. Focus on what you can do, not on what you can't. Tricia mentioned this, and I'll just hit it real quick. Engaging in healthy lifestyle behaviors, and the bullet points here, is incredibly important. Because if healthy lifestyle behaviors are over here, and MS is over here, and all of it is in you, then the more you can enhance other non-MS aspects of your life, the less you're going to feel the negative impacts of the MS. Okay? And ironically, we save this for after dinner discussion. If you want to find me in the hallway or Tricia, Tricia mentioned exercise. I'm tired, I feel fatigue. I can't exercise. Yes, you can. There are ways, there are creative ways. And the more that you do it as tolerated, and gradually, the stronger and less fatigue you're going to feel. It's one of the great ironies of exercise. We need it to keep ourselves going, and Stuart actually says it all the time now. I hear him. I need exercise. Give me a reason to walk around the room. Let me park far away from the mall. Oh, that's the reason. Okay. Lastly, I think I put this in. Take care of caregivers to avoid burnout. And I put it in with the caregivers, but I'm going to say it as a final statement to all of you. Going to see a psychologist does not mean you're crazy. If you haven't learned that yet, let me tell you that it doesn't mean you're crazy. There is a brand new wave of psychology. It didn't mean you were crazy 50 years ago, but even now there's a brand new wave called behavioral health psychology, of which I'm a practitioner. And basically, it's psychology to enhance areas of your life rather than focus on just the negative areas of your life. So if you are struggling in your family with understanding this MS and how it impacts you in your intimate relationships or within yourself, please seek professional help. Start with your primary care provider. They can triage you out to community folks. Or if you're connected with support groups or through online, through Stuart's site or other sites, you can find providers easy. And I highly encourage you to do that. They want to increase your overall well-being, not tell you that you're crazy and you're wrong for going to therapy. Very, very useful. Most psychologists themselves see other psychologists. That's how we get our magic. That's how we get it. Okay? Just take a look at this picture as we close. Remember, bearing any kind of burden. Tricia talked about the physiological burden that you see on the MRI. Let's just expand it out. Any kind of life burden or stress. When you bear it with 2 people, that knapsack is a lot lighter for each person. 25 pounds for me, hey, I can do it. 25 pounds for me, hey, I can do it. As opposed to one person lugging along the 50 pounds, right? Okay. So questions for me. Oh, here's a book. I'm not any way affiliated with this author. I just simply have read many books, and this, for this topic, is a wonderful book. So I show you the image and give you the title, and if you haven't already gotten it, I recommend it. It's a great read for this particular topic. It can really help you solidify some of the things we talked about tonight. So I think we have about 10 minutes, 5 or 10 minutes for some questions, and Stuart, again, needs to exercise, especially after dinner here. So make him work.
Make me work. By the way, for those that don't remember that I too have MS, but I don't remember I have MS because I don't have time. I don't have the time. I've given myself not a lot of time to think that I have MS. Instead, I'm doing for everybody else, period.
It's a wonderful coping skill. Actually, it is, to fill your calendar with activity.
Yes.
A question for you. Or for him. When do you draw the line, or is there a fine line between I forgot the keys. It happens to all of us, but I forget the keys every day. What is considered normal or warning sign or something like that that you can say, hey, this is happening more often, once a month, once a year?
Yeah, I once had a neurologist friend of mine tell me, if you walk out of the mall and you can't find your car, or Walmart or wherever, if that happens to you 3 times in 1 year, you need to call him. That's what he told me. So every time I come out of the mall, I think it's 2014, this is number 2. Oh shoot, I've got a lot of months to go and I only got 1 more left. It's a great question. As Tricia said, it's very difficult in these talks to give individual advice or treat from the podium. So it's difficult for me to answer that. I would say, depending on your own situation, if you can seek the loved ones around you to give you some input on, hey, is this becoming more of a problem for you? Does it seem more frequent lately? Would be my threshold for saying maybe we should check it out further. Does that help? Okay.
All right, I'm going to end this. I'm going to end this with a positive note of you and Trish together. If it was a perfect world and there was a cure and nobody had MS, what would it look like? What would it be like? What would the world and the day be like?
I have an answer, and then I will give Tricia the opportunity. So if I'm understanding your question right, in a perfect world for all of us, you're asking my perspective on what would it be like if we didn't have MS in it. My answer is it would be less of a perfect world, is my honest answer. Because I come from a place personally, this is going off, isn't really appropriate, but real quick, from a place where, as I said to you all before, if you don't have obstacles, if you don't have struggles, life becomes idle and a little bit boring, and I think it's actually worse to live in a world like that, for me personally, than in a world where I have to figure out how to deal with things. So I'm happy you're all here. I wish that the burdens that you carry and the strife that you go through in your life gets minimized. But I hope the process of going through to minimize it is a joy.
I'm not hoping for a world where we don't have MS. I'm hoping for a world where we can cure persons who do get, because I think inevitable persons are going to get neurologic diseases. There are whether it's MS or we trade it all for strokes, people are going to get them. The ability for us to be able to understand that, treat that, and get closer to a cure would be where I would like to live. But if we got rid of all neurologic diseases, I'd have to find another profession. What would I do?
Okay, question here. I'll get to the front eventually.
That's a tough question.
This is more of a comment than a question. When I sit at meetings like this, and I think about 20 years ago, when my daughter was diagnosed, and we went to the first neurologist we could find, and, well, you have MS. That was it. Today, I can see where so much more has progressed because of everybody like you all that are concerned and really bring to the forefront the knowledge, not only the medical part of it, but the everything goes in with it, with the psychological part of it, which is extraordinarily important. And the more of these meetings like this we have, the better off people will be with the knowledge for it.
Thank you. Anybody around here? Oh.
Biofeedback. I know there are many different types of biofeedback, but what would be an appropriate one for an MS person? You know, if somebody told me just go have biofeedback.
Mm-hmm. Yeah. I do biofeedback for anxiety. I probably defer to Tricia if she knows particular styles of biofeedback for particular presentations, because in all honesty, I'm limited to anxiety. But the way that I use biofeedback for anxiety with whatever condition is visual biofeedback. And for those of you who don't know, just in a nutshell, it's having your own output, your own temperature, your heart rate, your breathing rate be reflected visually back to you in some form. a waveform or something else. And being able to see that helps you regulate your own internal temperature, heart rate, breathing rate, and overall sense of well-being. So my answer is general, but the general biofeedback I use is galvanic skin response, heart rate, breathing rate with a visual display. So Tricia might have something.
So the majority of biofeedback that I'm most familiar with comes from physical therapy that use biofeedback and other disciplines in rehab that use biofeedback for pain and for spasticity management. And of course, there's biofeedback for bladder issues. So most of that comes from rehab medicine. So looking at dealing with a variety of symptoms. So a good physiatrist, which is a rehab specialist, is good with biofeedback. And there's different techniques depending upon the problem that you're addressing.
Thank you, Patricia. Okay, we have a question all the way up front. Da, 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 da.
Could you talk a minute about neuropsychological testing, its benefits, its goals, its outcomes, whatever?
Sure. I'll do it in a minute, too.
I was going to say, that's not a minute, but go ahead.
It could take a long time, but I'll try to do it in a minute. Neuropsychological testing, neuropsychology is the relationship between the brain and your behavior. Also thinking behavior, not just movement behavior. And so we do a series of paper, pencil, mainly interactive tests that assess your ability across multiple cognitive domains. So assess your attention, memory, thinking skills, sometimes motor skills, processing speed, intelligence, all those things, okay? And what we do is we look at your performance, we get numbers, and we look at your performance compared to thousands of other people of your age who are disease-free. And we call that the normative group. And when we get a score for you in a particular category of attention or memory or whatever, we can then compare that score to where the score, let's argue, should be for an average person. Then we can begin to infer how far away from that norm do you lie at any given time. So that's the purpose, and that's the general process. What's the benefit? And Tricia, I hope you support me on this. Just like with MRI technology, to look at, with each new flare-up of your condition, to be able to objectively show what you as a person look like, whether it's on an MRI or according to scores on tests of those domains, it helps us understand how your disease is progressing. And it also helps us correlate. When you say, I feel like I'm losing my keys more frequently now, I can give you some feedback and say, well, compared to thousands of people your age, your memory actually falls within the normal limits, or you have some mild impairment. And then 3 years ago, when you come back and you say, I haven't lost the keys as much again, let's do another round of neuropsych testing. Interesting. You're a little bit above average, your memory is right now, so you're doing good for you. So it's a way to objectively define your cognitive skills as you progress.
Any other questions? Well, then let's give a round of applause to Justin Koenitzer for coming here today. Again, if you have any questions for any of us, firstly, we'd like to thank you all again. We'd like to thank our sponsors again, Questcor Pharmaceuticals, for giving us the grant to do tonight's program. I want to thank both I would like to thank Patricia Pagnotta. I would like to thank Justin Koenitzer for coming out here and giving their presentations to educate you all. Remember, we educate. Educate, inform, and provide resources is what we do. Thank you again for coming tonight.
Thank you.